The speaker for this presentation is Paul Palevsky.
I'd like to thank Dr. Mehta and the organizing committee for inviting me to give this talk. Although a clarification, the actual workshop was not on prevention of contrast-associated AKI, but was on the management of patients with kidney disease in need of cardiovascular catheterization, and was much broader than just preventing contrast-associated AKI. This was a workshop that was originally planned for June of 2020, and as a result of COVID got pushed back and ultimately held as a virtual workshop over some weeks in September of this past year, jointly sponsored by the National Kidney Foundation and the Society for Cardiovascular Angiography and Intervention. The focus of the workshop was to address issues of cardiovascular interventions, procedures done in the cath lab in patients with underlying kidney disease. And we focused on three broad areas: coronary procedures, valvular procedures, and peripheral vascular procedures, with obviously the coronary procedures being the ones most commonly performed. This is an interim discussion of where things stand from the workshop. The workshop report continues to be edited and has not yet been finalized, and we hope to have it done within the next couple months. So we had, before the meeting started, the various work groups were assigned questions to address. So the work group 1, addressing coronary procedures in chronic kidney disease, had a large number of questions, starting with whether acute kidney injury is really a significant concern in cath procedures being done for coronary artery disease. Second question was what procedures should be considered for these patients. We talking about surgical versus non-surgical revascularization? Are there different outcomes for percutaneous interventions in CKD patients versus the general population? Is there an impact of LV support devices? Is there a difference between dialysis and non-dialysis CKD patients? And one of the key questions, and this is one that we kept coming back to, is this question of the population that should be included or excluded in procedures, and this key question of renalism, the failure to perform procedures in patients because of fear of inducing acute kidney injury. Does it occur? How frequently does it occur? What's the impact on patient outcomes? And the flip side of it is the new data that came out from the ischemia and ischemia CKD trial about the appropriateness of revascularization in patients with stable angina who have chronic kidney disease. What were the best practices for coronary artery procedures in CKD? Medications, how should they be adjusted for metformin, nonsteroidals, SGLT2 inhibitors, and even RAS blockers? The choice of contrast agents, volume management, the use of contrast-saving devices such as automatic injector systems or devices that divert contrast to minimize the contrast load. Does forced diuresis minimize the risk of complications? And what's the appropriate approach to staging procedures? Should procedures be done in a staged fashion or in a single sitting? And if done in a staged fashion, when is it safe to give more contrast? How much time should there be between staged procedures? And finally, the group was asked to identify and prioritize research goals. The second group looked at valvular procedures. TAVR in particular, but there are also mitral valve procedures that are being introduced. What's the incidence of acute kidney injury associated with these procedures? How should it be defined? Is AKI caused by the procedure itself, or do other factors cause it? And what's the evidence for this? What's the impact of AKI after TAVR on clinical outcomes? The mechanism of kidney injury, is it the contrast? Is it atheroembolism? Is it something else? What preventative strategies should be used? In patients with premorbid chronic kidney disease, does the degree of kidney dysfunction impact the outcomes? Does renalism occur in these, exist in selection of procedures for these patients? Does the type of valve make a difference in terms of the incidence of AKI? How do TAVR procedures come, and what are the outcomes in CKD patients? Is there earlier valve failure? And again, identifying and prioritizing research goals. Similar sorts of questions for the peripheral vascular disease group. Are patients who get procedures for peripheral arterial disease different than patients who get coronary procedures with respect to AKI risk factors? Are there subsets of patients more at risk, such as patients who have critical limb ischemia versus patients who have stable claudication? Can we predict AKI risk? Same questions for the coronary procedures in terms of isoosmolar versus low osmolar agents, volume of procedure, volume expansion in the role. What's the role of CO2 angiography? And can that prevent the development of AKI? Is there renalism in the care of patients with peripheral arterial disease? And again, what are the research goals in these patients? So let's come back to this issue of renalism, because this really was a very key aspect for all of the discussions. And renalism is a concept that was developed by Glenn Chertow a decade and a half ago. And it's defined as the failure to perform appropriate diagnostic or therapeutic interventions in patients with chronic kidney disease due to concern about the risk of AKI. And Dr. Chertow had shown that in patients presenting with acute MI, that if they had underlying CKD, they were about half as likely to undergo angiography. They were less likely to be revascularized if they did undergo angiography. Patients with CKD had much higher mortality, but after looking at the propensity-adjusted odds of death with angiography versus without, in patients who had angiographic procedures, the risk of mortality, one-year mortality, was reduced in these CKD patients by about, or was lower in these patients by about 40%. So demonstrating that patients with CKD are less likely to undergo angiography and are probably more likely to have one-year mortality as a result of the failure to undergo angiography. And this failure to undergo procedures because of CKD has continued to be an issue. So this is more recent data from 2018, demonstrating in the green lines, left side coronary angiography, the right side percutaneous interventions. The green line is CKD on dialysis. The red line is CKD not on dialysis. And you can see that patients with CKD not on dialysis are significantly less likely to undergo both diagnostic and interventional procedures than either patients on dialysis or patients without CKD presenting with non-ST elevation MI, where there's a strong indication for cardiac interventions or cardiac angiography. So what were the key recommendations? And these are the broad themes that are coming out of the groups. So for coronary procedures, while contrast-associated AKI is an important concern for patients with chronic kidney disease undergoing angiography. It really is overweighted in clinical decision-making, leading to underutilization of cardiac procedures. That the current risk models for predicting AKI are inadequate and need to be revisited. The models are out of date and really need to be improved upon. Periprocedural fluid administration represents the primary strategy for AKI risk reduction, but that the fluid management really needs to be individualized based on the severity of the CKD and the presence and severity of heart failure, be it left-sided, right-sided, or biventricular heart failure. Pharmacologic therapies have not been shown to be efficacious, with the strongest data against the use of N-acetylcysteine. That shared decision-making should be key in choosing between surgical and percutaneous revascularization procedures in high-risk patients, that contrast-limiting strategies should be considered, and that high-risk patients should have early follow-up of kidney function. For the valvular procedures, one of the key observations was that AKI is often multifactorial and depends upon the broader comorbidity profile, particularly exposure to hemodynamic variability and exposure to other nephrotoxins, not just contrast. That additional prospective studies are needed to identify independent risk factors for AKI following these procedures, that there's a need for more uniform reporting of potential AKI risk after cardiovascular procedures, that the impact of AKI on short and long-term outcomes should be evaluated based on the stage of AKI, that the rate of these AKI outcomes need to be adjusted for underlying comorbid conditions, and that the impact of transient or prolonged and complete or partial recovery of AKI after valvular procedures needs to be evaluated in terms of their clinical outcomes. With regard to the peripheral vascular procedures, there was recognition that there really are few studies in peripheral endovascular procedures testing strategies to mitigate the contrast-associated AKI, and that while prophylactic fluid administration remains the central intervention to mitigate the risk, the optimal protocol and target population for fluid administration remains an area of controversy, and that epidemiologic studies suggest that limiting the dose of contrast may be important in mitigating the risk of AKI. I want to conclude just by recognizing the participants in the procedures. The names are listed here. The individuals with asterisks next to their names also participated in the plenary sessions, giving plenary talks to guide the workshop. And with that, I thank you for your attention.